Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
And this is the show for today on Auburn Medical Group live stream with your favorite.
Hey, that's me.
Or this one.
That's you.
I was saying your favorite, so you're pointing at yours. I was pointing at
Oh.
mine. But thank you for joining us. We're going to be talking about false alarms.
False alarms?
Didn't mean to scare you there. It was a false alarm.
This is not a false alarm. You got that notice on your phone, not a false alarm.
Oh, that may have been, so people, they may have thought I was like playing with the streamers. Anyway,
what's going on?
Thank you for coming. We do have Lindsay Antwine present. So thank you, Lindsay Antwine, for being present, being a part of the show. Other people out there watching can also chat in and be a part of the show with your comments or questions. Depending on how many we have, we may only pick the ones that are relevant to what we're talking about. But if there aren't that many, you might be able to slip in a "what's wrong with my toe" type question that sometimes comes through. They sometimes make it in. We try to screen them over here. So I before we get to false alarms, which we will,
false alarms.
Think of all the dinging you hear in the ICU if you've ever been one, or I guess even regular patient rooms might have some kind of alarm.
They've got some, yeah.
So we'll get to that. But, Dr. Wayne, do you know what I did just like half an hour ago or less?
I have no idea.
I updated 2 of the 3 or 4 programs that we use.
To
make
so
the
is everything
stream work.
working?
That's
the question.
I knew better. I really did.
You did it anyway.
But I thought, it'd be cool to have this new YouTube live control panel here that shows you how many people are. I thought maybe it'd have functions for working with the chat, but it just has a chat. Right? Okay, we have other comments and questions here. We have. Oh, somebody knows about the Green Knight. It's Hilda Bauer.
She was probably reading my handle.
Oh, that's right. That's on there. Yes.
Dr. Green Knight. Yes.
So is the Green Knight a superhero?
No, not like the Green Lantern.
Or Green
Goblin? That'd be a
No.
Be a bad guy.
Green Arrow. Maybe that's the one I'm thinking of.
Green Arrow.
Is it Green Arrow?
I don't think so.
Who's the Arrow guy? He dresses in green. Hangs out with the Flash.
He hangs out with the Flash. It's like
Tell me if I'm wrong. Does anybody else watch
the guy that hangs out with the band?
Drummer.
The drummer, yeah. Who do you call the guy that hangs out with
musicians?
The superheroes?
And then what type of doc are you? Should we say it in unison?
Yeah.
A good one.
Oh, a good one.
Okay, we'll work on that. Apparently, we're not the best at synchronization.
Not that kind of doc. Synchronized docs.
I guess you call us family medicine. Dr. Gwen is board certified and residency trained in family medicine. I am not, but I do it. So there you go.
Yeah.
Nobody complains.
Nobody complains.
Put that in your pipe and smoke it. Because
you feel a little snarky today.
The Dutch Brothers was supposed to
thank you.
amp me up a little bit for the show, and I guess it did. I was looking at it, and it said, "Let's take a selfie." Dutch Bros.
Did you do that?
So let's do that now. Are you guys ready?
Make sure you hashtag that.
Okay. We're gonna get a selfie with our audience here behind us.
They can be able to see
They'll be able to see. All right, there you are. Right. I can't push the button and point. Anyway, I'll show you where you are.
There you are.
That's you there in the middle.
You're in the selfie.
Of the selfie. Thank you for
joining
made
us.
Okay.
Hashtag Dutch Brothers.
We're also YouTube doctors too, I guess, besides being family medicine.
YouTube doctors, I guess.
Yeah, kind of. Yeah. YouTuber is another title. So false alarms. Mainly we're talking about the ICU. That's where most of the alarms are in patient care. There's other things that come up like, in our electronic medical record, you were talking earlier.
Yeah. Because you were saying these false alarms, they come up, and we'll get into why we're talking about them false alarms, that we kind of just dismiss and put away. But we get all of these pop-ups, and sometimes you get pop-ups, they aren't as alarming once you get them every single time you do something. So it's pretty easy to
pop up in the attic.
Dismiss it. What?
Just the fact that you said that shows you're not ready for it. Okay. Lots of alarms. Yes. There's a shadow on my face. Do you see that? See, watch. If I go like this. Wait, where was it?
No,
Where'd it go? Where's the shadow? There. Look at my forehead. It's less shiny when I go. It's this microphone.
Yeah, I was gonna say it's the mic.
There, it's right in the middle of my face when
Obstructing
I rest back. Makes me
I think you'll be all right.
poorly lit. Okay, we'll work on that. What were we talking about?
Everybody saw it. False alarms.
False alarms. Yes, you were talking about the ones with like the drug interactions.
Pop-ups, yeah, for interactions.
When they keep coming up over and over, you can almost get to a place where you don't read them. If that's,
Yeah, well, you read like the first few lines and, I've seen that one before.
To make sure it's not something critical like
Yeah.
this patient's had anaphylaxis to this
allergy
drug before.
against this.
Right. Yeah.
for sure.
And why is that? Why does the fatigue occur?
Because it happens so often. It's just over and over again. You just get to a point where,
But if it's important,
oh yeah. So if those were popped up and they were important and it actually made me change what I was doing, then I'd recognize them a little more. But because it's often like, oh, read through this. Oh, that's nothing. Click. Oh, read through it. Click. And then you get
so your past experience of them not being relevant
it informs my what I might do.
Yeah, and so if 90% of them
90%
are irrelevant to what's
I
going
was gonna
on,
say, which could be true,
or don't
Could be
make a
that high.
difference, is there valuable to even having them at all? Because it gets to a point where you just tune them out.
Right. Yeah.
So even if there was an important one,
It'd be hard to differentiate it.
now thankfully, when it comes to drug interactions, when we're prescribing on Epic,
Yeah.
there is some kind of a prioritization to them. The
Absolutely. Yeah.
the serious
They've got a
ones
color,
are done differently,
different
so you
color
kind
in
of
there.
it catches the corner of your eye, and you're like, wait, this one
Yeah.
matters. And then there's all the other ones that come up so often.
Yeah. Lots of pop-ups.
Lots of pop-ups
Little.
in Epic.
Yeah.
And the ones that get our attention are the ones that won't let us do anything else for the
Until we
rest of the day until we
through it. And
until we
which
fix
is good.
whatever the
which
problem
I guess
is.
But a lot of them, you're just like,
well, it's like, how do I sign out of this chart? I did a note when I was on call and
right.
on the app, and now I can't
yeah.
close the chart.
Yeah.
Yeah. So the real topic though was based on a study that was done, is published in a journal about informatics, JIMR, I think it was, back in 2000, and done by a group in Rio de Janeiro.
Oh.
And they were studying ICU alarms, and they had a lot of data. They were reviewing the literature and finding pretty consistently, you find people saying that 90% of the alarms, no clinically significant action is taken on them.
Wow. 90.
And then they were documenting how many alarms an individual patient would have in the ICU. And it ranged from like a dozen to 40. And then they're talking about in the operating room, there could be at a maximum in some special situation over 120 separate alarms.
Wow.
And then they documented how many of the people who are responsible for responding to these alarms even know what all of them are.
What they mean. Wow.
And they couldn't find somebody who knew what all of them were.
All of them.
You know, a nurse in the ICU,
Mm-hmm. Yeah.
all the possible alarms that could be going off with the monitoring equipment that's on the patient. They may not actually be oriented to every single one.
Sure.
But yet we're able to practice medicine through this nonetheless.
Yeah.
With alarm fatigue being that situation where people just either are slow to respond or absolutely don't even respond to an alarm because of its overuse and being associated with nothing significant for the patient. It reaches a point where, alarm's going off, turn it off. Well, aren't you gonna see what that was? Well, no, it's never anything. So
Yeah. Right.
well, why are we enabling it in the first place?
Why is that even?
So
on?
that's the problem that exists, and that this group in Rio de Janeiro is trying to come up with some kind of way to help it.
Sure.
I bet you're just sitting on the edge of your seat there wondering what they came up with.
Well, I was thinking about all of the alarms when I did my ICU rotation. I haven't been in an ICU in over 10 years.
Wow.
So, but like I'm thinking about some of them where there would like be a beeping, and it was like, the pulse ox had come off, and they pushed a button, or like some small thing on the heart monitor or something that showed something and wasn't clinically significant. So yeah, I can definitely see that.
So yeah,
and I've
you're talking
experienced
exactly
that,
what it is.
Experienced some of that.
So in this study, they came up with a way to track the patients with GPS and to track if they were moving in their stretcher or bed.
Yeah.
And to find that if that's what set off the alarm, there's a certain probability that the alarm was not clinically significant.
That makes sense.
You know, like
yeah.
if
Like
you turn over and
like you
it
pulled
pulls
off a monitor. Or,
Yeah. Not that somebody couldn't have movement associated with a bad thing. So that's something that needs to be considered.
My chest hurts.
Yeah.
So I'm moving.
But more often when there's movement going on and
Causing
then the alarm goes off, it's due to the sensor coming off, and it just, for example, for an EKG, it will turn to a flat line.
Right.
Because there's no signal that it's monitoring. Pulse ox,
I've seen that. I've seen a flat line while the patient's there sitting
talking to me. Eating their cafeteria
Obviously
food,
not a flat line.
The low sodium diet right there.
Yeah, right, exactly.
And the line goes flat. Yeah.
Well,
it's because they
get out the paddles.
They lifted up their arm and it pulled off the sticker that's connected to the monitor.
Yeah.
So they were able to come up with a way of taking that information before the alarm went to whoever's responsible for monitoring it, and giving them some kind of a probability that this is real.
Okay.
And so they were able to measure, and I didn't finish the article actually. I don't know how it ends.
What?
My guess is
on the edge.
My guess is they found
this is
that
crazy.
They could, and what did they call the probability? The FAP, the false alarm probability. The FAP. So they were fapping in this article. Now, I know what you're thinking, and it's not female adenomatous polyposis FAP.
They're all thinking that.
I know. So they'd come up with a score, the FAP score, and that based on that, they would be able to tell whoever's monitoring it how likely it is that it's something significant. So let's take a little break here.
Yeah.
Let's go to you, our audience, and see what your comments and questions are right now. Because there's so many I have to scroll. So we have Darla. Where's Darla?
Darla.
She says, I saw a new one today. They were for psychobiotics.
I don't even know what that means.
I don't know how that fits in with anything we've said yet. Okay.
So I knew something.
And Lizzie says, Hilda, not sure yet. And Lindsay, I generally hope the staff in the OR are paying close attention to the entire situation with 120 different alarms going off.
It'll be hard.
They're paying attention to certain ones.
Certainly. Yeah, this is mostly
oxygen and carbon dioxide.
Right, I was going to say mostly on the side of the anesthesiologist.
Yeah.
And
usually that's
there.
Angela, please, if you speaking to me at Hilda Bauer, you're having your own conversation. I took too long to get back to the chat, and they decided to talk to each other. Okay.
Oh, yeah, because I guess she had, when I was hospitalized, that Angela ate the first one.
Lizzie's of the opinion, they should be checking every single alarm. Scary if they aren't. Spoken by a true person who hasn't worked in the ICU.
If a patient's there talking to you and you see a flat line, what do you need to do?
You need to hook it back up.
You need to hook it back up and turn off the alarm. That's what you need to do.
Turn off the alarm, yeah.
It's not like...
there's an excess of alarms.
Right.
And it needs to be... See, there's been there probably is now. I'm sure some institutions are recognizing this because we have this alarm fatigue term. So I know people are working on it.
It's a thing.
But we've had this technology racing ahead of some kind of assessment of how are we going to deal with this. And probably the decisions are being made by people who aren't actually at the bedside monitoring it, responsible for all the monitors, but rather being told, here, we're installing this monitor on all the patients now.
Yeah.
There's ways that these things get out of control. And of course, people, being the adaptable creatures that they are, come up with ways of adapting to the situation they're put in. And they prioritize what's important. Okay, the patient's breathing. Okay, if you need to, you arouse them. Patient arouses, if you shake them or whatever. So they have ways of coming up with dealing with these challenges that are presented to the people who have to work with all of the alarms.
Right.
Okay, and then Lindsay's saying, y'all don't make this so easy for me. I wonder. She said that
What
at
did we serve her up?
4:43. I'm wondering.
What
when that
were we
was.
saying?
Okay. So, Lizzie, well, nobody was talking to us, so we were trying to wonder what alarms they were talking.
Yeah, I think there was a question about
So,
heart monitor,
heart rate, carbon dioxide, oxygenation, blood pressure.
Yeah.
Their weight probably isn't changing fast enough to set off an alarm while they're laying in the bed. Intracranial pressure.
Swan scans.
Swan scans would have pressures in different parts of the vascular system.
Yeah.
So they can monitor, pulmonary artery pressure or wedge pressure.
Yeah. I think
What else?
It's like everything.
Did I say
all of
intracranial
those.
pressure already?
Yes, I think you did.
Yeah, those are the ones that we think of most commonly.
Yeah.
I'm sure there's a lot more because I didn't come up with a dozen. So, and they said that's where they start. Hilda, I'm at alarms in the ER. There's so many
Oh, man. Yeah, same thing.
A lot of the same. We're talking about a lot of the same monitors.
Similar equipment.
Yeah.
So, yeah.
Okay. And then Lizzie's thanking me. Okay. I love how the nurses ignore the call button.
Well, that's an alarm.
They're probably getting to it, but they somehow make the one with the heartbeat stopping a priority over the nurse call alarm. So, yeah, it's all prioritization.
Now, I can tell you from some of the nurses that I work with that some patients abuse that nurse call button, just so you're aware. So, they are not your waitress. They are a nurse. Am I getting in the way of a patient experience here?
Are you sure you are the patient experience or the service excellence?
I gotta look out.
director?
I gotta look out for nurses because they are wonderful and what they do is amazing. And no, they're not.
It shouldn't be called nurse call button because it shouldn't be the nurse. It should be the nurse's aid.
There should be something first. Yeah.
Nurse's
I mean,
aid
yes,
button.
sometimes you need the nurse for something. Yeah. But oftentimes if you need help to the restroom, that's not always the nurse. That's usually an aide. Or if you need
dietary issues.
Yeah. I was gonna say some food thing.
Where's the remote control? How to use this phone? How do you get
random things like that? Yeah, somebody else could take care of that. So.
Okay.
But anyways.
So Angela H. If the machine's measurement doesn't matter, then it shouldn't deny the patient sleep. Oh.
Yeah.
Oh.
Yeah. Angela,
Ooh.
she made a comment here
Angela,
earlier when
yes.
when I was
she's keying into
hospitalized.
this, not just the staff that's getting fatigued or irritated by all these alarms.
You missed her earlier comment,
I
her
did.
first
Okay.
comment about not being able to sleep when she was having all these alarms go off.
Yeah.
So, yeah.
Well, it doesn't mean all patients are abusing that
I
call
know.
button.
I'm not saying that, but
See, you asked for it, man. You put it out there, and it defines can be an emergency that needs immediate attention.
someone
Can
needs
be.
Immediate attention.
Sometimes it
then
is.
We should give immediate attention. Absolutely.
That's right.
Yes.
And that's exactly the point we're trying to achieve here is that that ability to tease out what's actually needing attention has been impaired by the call by the alarm fatigue. Yeah, and the alarm fatigue probability, the FAP needs to be determined.
Sure.
Okay. So Lizzie, where's Lizzie? Definitely, she agrees with either you or me or both, or somebody who commented before.
Probably me.
There we go. So yeah, you said your ICU exposure is like
Way in the past.
way
Way in the past.
back, 2011. No. Wait.
It would have been around then.
Whereas for me, if I go over and visit a patient at the ICU, which I do on occasion, across the street, I'll actually be in the ICU hearing alarms.
Yeah, I mean, I've had that, yes, but
Yeah.
no, as a clinician working in the ICU, it's more than a decade now.
Okay. All right. So that wraps up our discussion of
False alarms.
false alarms. We thank you for participating in the chat, and we're sorry we were so dismissive of patients and our audience both. Please send angry letters to Dr. Gawain at his house somewhere in Christian Valley.
Hey, I was gonna say you've got my Twitter. Just tweet at me. Oh, you can't accept me. Whatever it is.
Accept? Is that what they say now? All right, let's put it up so they can find you. There you go. That's how you find us.
I'm not on there that often, though.
Remember, Dr. Green Knight is where to send all the angry comments, and everything will be. Oh wait, we have more
Yours
comments
is up
here.
there too, so
I'm not able to put comments when that's up there. So Lizzie's saying
more comments,
they could put all the bad patients on one side of the ER.
and then all the good ones. How do we tease that out?
Actually, I'm thinking about how that's actually done.
There is an area. Most
Remember
ERs.
my story about all bleeding stops?
Yeah.
Yeah.
Yeah,
Okay.
yeah.
All right. So until next time,
Hey, I'm Dr. Gawain.
and Dr. Mark Vaughn telling you to stay in good health.